Hi everyone, we are getting ready to start chapter 4 and 5 today. I'm going to try to do this in one video. Hopefully it'll work. Chapter 4 is all about cancer. They have cut down a little bit of information in the book, so I may, mention some other things that I think that you should know. I'm going to be, of course, looking in the book, and I'm also going to be looking at the PowerPoint. I'm going to read the intro on page 58. This chapter is a general introduction to cancer. Specific types of cancer are covered in the appropriate system chapter. Cancer is characterized by uncontrollable growth of abnormal cells in the body. These abnormal cells infiltrate normal body tissue and in some cases spread or metastasize. Cancer is not just one disease. There are many different types of cancer. Cancer affects the young and old and involves nearly every tissue or organ in the body. Okay, so let's begin with the epidemiology. The first thing we need to talk about is a few little terms. The first term I want to talk about is neoplasm, and this does not mean cancerous. It just means an uncontrollable growth of cells, and usually abnormal cells, but it does not mean cancerous. Then we have a metastasis is another key term for you. That means that it's spreading to various parts, maybe the organs that are close in proximity, or it could be, let's see, liver cancer that spreads to the brain and the lungs or the blood. That's usually some of the last places that cancer will metastasize before death occurs. And then you have the key term epidemiology, okay? And epidemiology talks about, the origin of cancer, how it studies cancer. So that's epidemiology. You can look at Table 4.1. It gives you the leading sites of cancer that are common today. So men, of course, we worry about prostate, and then we do lung, colon, and rectum, urinary bladder, melanoma, etc., etc. And then women, of course, are breast, the lung, colon and rectum, uterine, thyroid, and non-Hodgkin's lymphoma. And I do want to say, I think even since this has been published, we're seeing more and more ovarian cancer, more kind of almost even with breast cancer, or maybe right underneath breast cancer. So you don't have to know that those are the most prevalent, but those are just some of the cancers that we're going to be discussing. And then the Table 4.2 gives you something similar, except it discusses how many have died, the whatever the cancer is, and according to death. So men, lung cancer, women is lung cancer as well. Table 4.3 is the leading sites of new cases of cancer worldwide. And then you have Table 4.4 is the leading sites of cancer deaths worldwide. And you do not have to know those, but I did want you to just look at them. It's interesting facts. So let's look on page 59 at tumor formation. And like I said, neoplasm is like a new growth or a tumor. That's another word for it. So what happens is when we have, what makes tumors is we have so many cells in our body, and they will die, and then new cells come along. And sometimes when those new cells come along, when they begin dividing, they divide abnormally, and that's what can cause cancers. And then of course certain risk factors that we have in our lives can increase the chance of those cells dividing and causing abnormalities within the cells. So then benign and malignant are two terms that are very important dealing with cancer. Benign, of course, means non-cancerous, and malignant means cancerous. Okay. I also want to add a term here that it shows you in a table in this chapter, but I don't believe it really tells you what it is, but it's in situ. And that is IN and then a separate word SITU. In situ. That means that the cancer is encapsulated, okay, within the organ or outside of the organ. So in situ means encapsulated. Make sure you remember that. Let's see, keeping on going here. Let's talk about how we name tumors. Usually when we have the physician will find like a lesion or what we call like a polyp, and that's one of your key terms too. And these are usually benign, and sometimes when they're benign, it's all good, and then sometimes when they're cancerous, they're considered a carcinoma, okay? And then we have different types depending on where it generated. Like if we had a polyp or carcinoma in the fatty tissue, it would be considered a lipoma. If it was, let me see, there's a table here. Table 4-5, if it was in the vessels, it would be an angioma. In the muscle, a myoma. So if you look at table 4-5, it kind of shows you what the different prefixes that of where different cancer can originate. Excuse me. So make sure you look over that, because that's a really good, useful table for good information. Okay, I want to look on page 60. You have another word called sarcoma. Okay, sarcoma is a malignant tumor of the supportive tissue. Okay, so we usually call those sarcomas, like an osteosarcoma. Okay, because it may be with the bones or the spongy tissue of the bones, or it could be talking about the joints as well. And that's sarcoma. All right, going on to known risk factors for cancer. The biggest thing is age. As we get older, our organs just, tend to slowly shut down. And age, when that happens, cells are going to be changing, and so that's when we're most at risk for age. We've also had, when we're older, we've also had a lot of exposure to various environmental factors, physical factors, and that can change our cells as well. Infections, I'll give you an example of infection that can cause cancer. The human papillomavirus, or HPV, that can happen in men and women. Some strains of it can cause genital warts, and some strains do not cause genital warts. But it's usually due to multiple sexual partners when intercourse wasn't using a protection. So basically the different sperm on the cervix can cause abnormal cells, and that's how we get HPV and cervical cancer. But anyway, HPV, which is an infection, can cause cervical cancer. So cancer of the cervix, and that's considered a cancer. So that's an example of how infections can cause it. Radiation, when we're exposed to radiation. Let's say I'm a rad tech and I haven't been using the proper protection, or I'll use let me use a better example for unintentional radiation exposure. For my husband, he used to work on Navy ships, and they had radar there, and so he was continuously exposed to radiation. This can cause cancer because the radiation penetrates our cells and they can begin to change. And then we have immunosuppressive medications. Anything that's going to suppress our immune system can definitely cause cancer because it works on our body's cells. So anything that's going to change cells can cause cancer. Not usually right away, but in the long run. Going back to infections, some other infections that are common are like all your hepatitis viruses, anything that, all of these diseases within the liver can eventually cause liver cancer. The Epstein-Barr virus, this is, what causes mononucleosis, so this can increase the risk for lymphoma and like a nasopharynx cancer because of the monovirus. Let's see, H. pylori, which is a bacteria that gets into the stomach and it causes ulcers. Well, if we have ulcers in our stomach, that can really lead to colon cancer. So those are just a few of your your different types of infections. Let's see. Going on to signs and symptoms of cancer on page 61. These can depend, depending on the location, what size it is. If it's very small, we may not have any symptoms or just a couple. If it's very large or it has a huge metastasis, we may have a lot of symptoms. Unfortunately, a lot of the deadly cancers do not have symptoms, and that's why all of a sudden, your loved ones or your friends may be diagnosed with end-stage cancer of some type, and they didn't have any symptoms. Or maybe they were just beginning to have symptoms, and they go to the doctor and they find out they're at end stage. So that is one unfortunate thing that can happen with having no signs and symptoms. But it does depend on the location, the size of it, how much of the organ is affected. If it's only a little portion, of course, it's not going to affect too much. But let's say I have cancer of the liver that I may not know about yet, and it's the entire liver, then I may start having some digestive issues and metabolism issues. And then if it's metastasized, we may start having symptoms of a cancer where it's metastasized before we know where it originated at too. So those are all some of the things that we have to look for. Some of the basic signs and symptoms of cancer are unexplained weight loss. That's a big one. And then, of course, with that, you have to take in consideration if you're taking certain medications that can curb your appetite, and it doesn't have to be diet related, or that can just cause weight loss. That is probably why you have unexplained weight loss. Fever, unexplained fever, or fever of unknown origin, that's abbreviated FUO. Fatigue, pain, and skin changes. So those are just some of your most common signs and symptoms. Let's see. The etiology of cancer. Remember, etiology is like the cause of cancer. So some are idiopathic, which means we don't know what the cause is. And so, when researchers are trying to figure out treatments, they have a very, very hard time. Usually the first place we look is their habits in their environment. Then we look at their family history and their lifestyle. Family history or genetics can play a huge role in this. Environmental factors, where do they work? Where is their house located? There was a place in Alabama back several years ago where they found cancer, little carcinogens in the soil because they were starting to see like an abundance of new cancer cases. So they were testing the environment, tested the soil, and it contained carcinogens. Genes is another thing that can cause cancer. We have different types. We have oncogenes, which means these are cancer-causing genes. We have tumor suppressor genes. We have what we call suicidal genes or suicide genes. And then we have DNA repair genes. Let's see. You can look over on page 61 to discuss, to read about all of those. Excuse me. Okay. So what happens is these genes begin to mutate in the body. Like I said, cells change, genes change, and that's how we get the cancerous cells. A carcinogen, you have that term on the bottom of page 61. This is a cancer-causing agent. That's what a carcinogen is. So nicotine or cigarettes, the tar, the menthol in cigarettes, that's considered a carcinogen because it's a cancer-causing agent. Let's see. Looking at the diagnosis of cancer on page 62, there's several different things we can do, and sometimes it's easy and sometimes it's not so easy. The first thing for a lot of tests that we can do is a blood test, and there's something called a CEA, a cancer, oh my goodness, what is it called? A cancer enzyme something. I can't remember, of course, now that I'm trying to tell you about it, but it's a CEA, and basically it's a cancer cell count. But that doesn't cover all cancers. That only covers like your breast cancers, colon cancers, and I believe ovarian cancer. So some of the common ones. And the CEA count, so that's an example of a blood test that we can do. And there are other blood tests that may clue us in that there could be, something cancerous going on. But the CEA is one of the things that actually checks for cancer cells. But just remember that it only will pick up on certain types of cancers. The big thing here is diagnostic imaging. Usually, and it's not on here, but it's called a PET scan, PET, positive emission tomography or something like that. PET scan is really neat because it's very similar to a CAT scan. But basically, when we scan the body with the CAT scan or the PET scan in general will show up like little hot spots, and that shows us where the cancer is. So that's really, and I know that doesn't list that in your book, I don't believe. However, I want you to add that because really the PET scan is the best diagnostic imaging. And then, of course, we have x-rays. We can tell that there's something like a lesion on the lung or something like that. Ultrasound, we can tell if, maybe you have ovarian cysts, and we can tell that they look abnormal. So all of those are good as well. But PET scans are the best thing to pick up cancers. The most definitive diagnostic tool is a biopsy. Okay, because even with PET scan, we can see that it's a hot spot, but we don't know for sure. The hot spot could be non-cancerous, but it's just showing like a change of cells. So the biopsy, we can biopsy it, and we know exactly how large it is, and we can stage it when we biopsy it, and we'll get to staging in just a second. So biopsy is the most definitive diagnostic procedure to do. Let's see. You have a lot of pictures here of things or pictures that are in your book as well. Let's go on to grading and staging, still on page 63 and on slide 23 in your PowerPoint. Grading and staging is a very important part of cancer because we have to look and see where the cancer is, and then that depends on what type of treatment we're going to use and how many treatments that we're going to use. Because, if the person is in end-stage cancer and there's not a lot we can do, why try to put the patient through something like chemo, high doses of chemo and high doses of radiation if the outlook is grim? So that's the reason why we do grading and staging. So grading tells us the prognosis of cancer, like how far along is it. And we do a scale of 1 to 4 in Roman numerals, so 1, 2, 3, 4, and then of course 1 is like the beginning stage and stage 4 is the end stage. If you look at table 4.6, it tells you right here, stage 1 is where tumor cells almost look normal, except they're not, they're just getting cancerous. Then stage 2, they look slightly abnormal. Stage 3, they look abnormal. And stage 4 is very abnormal. So that's called staging. I'm sorry, that's called grading. My bad. And then staging is what we call the TNM system. Okay? So the staging is how we're going to develop our treatment plan. Okay? The grading, the difference between it, grading, we can figure out how far along the cancer is to see, and that kind of goes along with staging, which is to develop a treatment plan. So we're going to predict the prognosis of it, and then we're going to look to see if it's metastasized. So that's why I said it's called the TNM system. So T stands for tumor, and we're going to want to measure the tumor size. We're going to look at it in detail. And see if is it a primary tumor or is it a metastatic tumor, meaning that it's metastasized from another area, and that could also be called a secondary tumor. Then the N is the number of lymph nodes involved. Now, a lot of cancers, we have lymph nodes everywhere in the body, and if lymph nodes are around the cancerous area, it will spread to the lymph nodes, and then lymph, of course, travels throughout the body, so it can make it metastasize very easily if it gets in the lymph nodes. So N stands for lymph nodes, and then M stands for metastasis. And then it tells us where the cancer has spread. So the TNM system. Make sure you remember that. And if you look on page 64, table 4.7, this tells you some different things about it. For judging the tumor, they use different abbreviations. Same thing for lymph nodes and metastasis. They'll use different abbreviations. So make sure you look over that really well. Okay, looking at cancer treatment here, there's all different types of cancer treatment. Some we may want to do and some we may not want to do. And then, you have to really ask your doctor. If you're in stage and there's just very little, help for you, it's really not good to have a treatment, or maybe to only have palliative treatment for your signs and symptoms. So the big thing is surgery. If I had breast cancer, I would probably have a bilateral mastectomy. Same thing if I had ovarian or uterine cancer, I'd probably have a radical hysterectomy. So that's the big thing is surgery. Is to go in, they'll remove the area and other organs around it if needed, and they'll scrape all the lymph nodes away if they see that it's infected. Metastasized to the lymph nodes. Radiation, this is a big treatment. Radiation therapy on page 64. This can be usually external, but for certain types of cancers, they will put you into surgery to implant a radiation device inside your body that emits radiation within the body. Then we have chemotherapy, of course, is probably one of the most common, but chemotherapy and radiation kills good cells as well. That's why we lose hair with both of those, and we're very sick, especially chemo, because it does kill the cells very rapidly, and it can make us very sick and immunocompromised. Hormonal therapy, certain cancers like ovarian cancer or breast cancer can benefit from hormonal therapy. Immunotherapy, this is really something that stimulates the immune system so it's strong enough to fight off the cancer cells. If you're already weak from maybe a previous treatment of chemo, we may give the patient immunotherapy to help them become a little stronger so they can fight it off. So immunotherapy is not usually used alone. It's usually used in combination with another thing. And then let's go on to cancer prevention. Obviously, some of these are very obvious. Don't use tobacco. We need a healthy weight, physically active, stay physically active, a healthy diet, limit your alcohol intake. Protect your skin, get immunized. That's a big thing, getting immunized. Avoid risky behaviors like safe sex. Don't go with multiple partners. And the same thing, yes, we do want to have safe sex. However, certain things like the herpes virus that causes genital herpes, even if we use protection, herpes can transmit from skin to skin. So even with protection, we can still pass herpes on to the next person. So it's really important to practice, practice abstinence, of course. And then if you're married, monogamy, meaning one partner. And then getting recommended cancer screening. So women, we have to get breast exams. We're supposed to do monthly breast exams 1 week after your menstrual period. You're supposed to do mammograms, then men prostate exams and rectal exams, colonoscopies for both. So there's a lot of different preventative measures we can take. And that is it for chapter 4. So I'm going to switch the PowerPoint to chapter 5. And we'll keep going with chapter 5. And chapter 5 talks about heredity and disease. And this can be very confusing but extremely interesting as well. Because, each cell in our body is so unique. And then different things can happen, and I told you in the discussion board about the Hamby twins of Columbus that are going to be conjoined. So make sure you check out that discussion board. So let's look at chapter 5, starting with DNA and chromosomes. The DNA is considered the cell's master code. It's deoxyribonucleic acid. That's what DNA is. So it's the cell's master code. And then within it, that's how we figure out we have genes within the DNA. And so genetic is another word that comes from genes. So we may have certain genes from this side of the family. We may have the others from this side of the family, and that can it can provide different things like your physical attributes, your emotional attributes, things of that nature. Then we have chromosomes, and included in chromosomes we have what we call autosomes, sex chromosomes, and karyotypes. And the sex chromosomes are some of the very common genetic conditions that can happen while after conception, basically. That's when the sex chromosome, something can go wrong, and we can have a sex chromosome type of disorder when we may find out after they're born, but usually we find out while the fetus is still in utero. And then we want to talk about meiosis, and that's basically the splitting of cells. You can look at those pictures there, the karyotypes, and that's where it gets a little confusing. So let's look at genes and inheritance. Genes and inheritance, we need to talk about locus. That's one of the terms that we're going to look at. And basically, a locus is a gene that is in your body that's going to give us a trait, kind of like what I just mentioned a while ago. Alleles that are codominant and reduced penetrance, all of those, make sure you look over all of those terms. Let's look on 73. We have homozygous and heterozygous, okay? Then we have a dominant trait. Then we may have a recessive gene or trait as well. So some of you may remember this from high school possibly. But like I said, it can be very confusing, and I'm definitely not an expert in hereditary and genetic things, so I'm not going to go into extreme detail there. Going on to the human genome and disease, the genome is like our complete genetic makeup, our complete DNA. That's what the genome is. And then how our DNA is sequenced. So you've probably heard of the National Human Genome Research Institute. They do a lot of different things, and basically, it's amazing to read some of the things that we have found out through science. Alright, getting into the meat of this chapter, talking about hereditary diseases and how they're transmitted. For the first type we're going to talk about is autosomal dominant, and then we'll have autosomal recessive, etc., etc. So autosomal dominant disorders, the first one that your book talks about is Huntington's disease, and this is a neurodegenerative disorder. Polydactyly, oh, excuse me, I couldn't say that. This is when you have like an extra digit, so it could be an extra finger or an extra toe. And most of you probably don't know this, but we adopted our son. He was adopted from the U.S., but when he was born, I noticed that he had like a little, it looked like a little hard pimple. And I asked the doctor, what it was, and he said it was going to be another digit. So that would be considered something like that. That would be considered polydactyly. Achondroplasia, Marfan syndrome, and familial hypercholesterolemia, which is high cholesterol. So all of these are different disorders with autosomal dominant. Going back to achondroplasia, this is basically like dwarfism, results in dwarfism. The Marfan syndrome is we don't really have very good connective tissue. It degenerates and weakens, and so in return, we have a lot of problems, muscular problems, vision and joint problems. Excuse me. Now we're going to talk about autosomal recessive. Autosomal recessive disorders. Cystic fibrosis. You may find that these are more common and some that you've heard of more. Cystic fibrosis, this is a major condition, and this causes like extra or excessive mucus coming from the mouth. It's muscular, let's see what else your book says, respiratory infections. So you've probably seen somebody, at least one person in your lifetime, with cystic fibrosis. Hemochromatosis, this is a blood disorder, and it's like an iron issue. PKU, phenylketonuria, that's the thing that they test newborns with a little heel stick for, PKU. And this is going to be like a metabolic disorder that can lead, if it comes back showing, positive or whatever the results are, that can tell us that patient may have a learning disability of some sort. Galactosemia, this is inborn error of sugar metabolism. It can lead to mental development issues. Sickle cell anemia, you've probably heard of that, where the red blood cells, instead of round, they're sickle shaped, and it can cause death sometimes if we have a sickle cell crisis. Tay-Sachs, this is something you've probably heard of, but it's very rare, and it occurs mostly like in Jewish and Eastern European families. And usually if somebody has Tay-Sachs, they die in infancy. Then we have albinism or albinism. This is the absence of pigment melanin, and this is usually in African American. But usually they'll be African American, and they'll have their features. However, they'll have whiter skin, redness to the skin, redness in the eyes. So it's I'm sure you've probably seen a patient that was that's been like that as well. Going on to sex-linked inheritance, we have muscular dystrophy. Duchenne's muscular dystrophy. This is abnormal muscle development and not the wasting away of muscles. Color blindness is also sex-linked. Okay, and sometimes we may not know that we're colorblind until we eventually notice, like, why that is the wrong color, or somebody gives us a colorblind test. Fragile X syndrome, this is developmental disorder, and then another one that your PowerPoint doesn't list but is in there is hemophilia, and this is like a free bleeder, somebody that doesn't have the clotting factor in their blood. Flipping over to page 76, skip page here. Familial diseases. This is things that run in your family that some of those traits are hereditary, and they may come over into your body through your genes. So these consistently appear in families, and they're usually several genes. They're multifactorial. So you may hear that term instead of like a familial multifactorial. Let me keep going here. Abnormal chromosome diseases. These are some common ones too. We have Down syndrome. This is also called trisomy 21. Okay, Down syndrome is pretty common now. It does have the characteristic appearance, and you can see a picture on figure 5.9. All Down syndrome children have that certain look. Even infants have that certain look. They usually have a shortened lifespan. However, now they're doing more and more treatment to try to lengthen the lifespan. And they have a mental impairment, some severe and some not as severe. Sex anomalies. We have Turner syndrome, and this is when we only have one X chromosome. So the ovaries will not develop in a female, and then the testes will not develop in the male. Or if the male may be sterile and the female could be sterile, meaning not producing. Then we have Klinefelter syndrome. This is a pretty common one as well. And this is an extra X chromosome. And so basically this is very similar to autism and sometimes gets confused with that. But Klinefelter's is like it's a disorder, and it usually happens in male. The males, the appearance is usually like small testes. I'm going by your book here too. Maybe they do not produce any sperm. Female sex characteristics emerge. The breast may enlarge. Facial hair may develop. The general appearance looks like a very young adult. So the person is usually really tall and slender. They may have like extremely long legs, and they could have, behavior that kind of mimics that of an autistic child. And I was thinking there was a picture of a child with Klinefelter's, but I can't remember. I don't remember seeing it. The next thing is that I want you to look at is hermaphroditism on page 77. That is a true disease. I'm sure you've heard of that, and you thought maybe you didn't know that it was actually a real thing, but it is. Some people are born with the opposite sex organs, because when we're all in utero and developing, we have the same genitalia, and the different types of chromosomes that make up our genetics when we're forming determine whether that genitalia is going to turn into, a penis and testicles, or a ovaries and vagina. So everything, a lot of times if we have ultrasounds too early, we may think that we see like a little appendage or penis in the ultrasound. However, that does not necessarily mean it's going to be a boy. That could be just it could be a clitoris actually, and then the clitoris eventually goes up into the vagina when the vagina starts forming. So males and females always start out with the same thing, and eventually the chromosomes determine whether it's going to turn into that. And of course, when we start out with the same gonads is what we call it. And then the gonads, can change into, like I said, vagina and ovaries, or penis and testicles. So that's a hermaphrodite, somebody that has the opposite sex organs. Let's see, going on, let's look at some genetic counseling on page 78. The diagnosis of genetic diseases. The big test here for fetuses that, for people that are still in utero, or fetus that are still in utero, is the amniocentesis. And the amniocentesis is where they take the large needle through the abdomen and down into the uterus, into the bag of waters, and they take a sample. And then that's how they determine if there's any type of abnormalities. And they will not do an amniocentesis unless a sonogram shows up any abnormalities. Congenital disorders. Some of these include, you have congenital rubella, cerebral palsy, hydrocephalus, which is what we call like the water babies or water heads, spina bifida. This is where you have your spinal cord starts growing out of the skin instead of down the back. We may have a congenital heart disease, congenital disorder of the intestines, and then we have the cleft lip and cleft palate. So all of those are examples of congenital diseases. Alrighty, I think we will stop there, and if you have any questions, of course, just email me and I can answer them, because I know that these different genes, the different autosomal recessive, autosomal dominant, they can be a little confusing. So just let me know if you have any questions.